Hello everyone, we'll be discussing very important topic today, that is diarrhea. Diarrhea in children. Okay, so please do remember this is a very important cause of under 5 mortality. It is a very important cause of under 5 mortality. Okay, it is not most common cause, it is important cause. So diarrhea, you can just remember it's an acute diarrhea and it is a chronic diarrhea. Okay, now acute diarrhea or chronic diarrhea, the difference here that acute diarrhea are basically infective in origin, but chronic diarrhea, it is a non-infectious. It is non-infectious, basically non-infectious. Okay, acute diarrhea is less than 7 days, okay, persisting, but chronic diarrhea is more than equals to 14 days. And non-infectious means basically it might be due to malnutrition. Okay, malnutrition. Why malnutrition? Might be following malabsorption, so better to write as malabsorption. Okay, we'll be talking about celiac disease. Okay, like in celiac disease also you'll be find this thing, so malabsorption. Now another important thing is this one. Now then, if acute diarrhea, that is a diarrhea which is less than 7 days, which is an infective origin persisting more than 7 days. Okay, so if this is persisting more than 7 days, okay, if it is persisting more than 14 days, which is also called persistent diarrhea, which is also known as persistent diarrhea. Okay, so let me summarize the differences here, what I have told. Acute diarrhea, please remember guys, acute diarrhea means it is an infective diarrhea which is less than 7 days. But when this infective diarrhea going more than 14 days, it is called persistent diarrhea. So difference between persistent and chronic is both are more than 14, but one is infective, another is non-infective. Understood? Okay. Now, coming into the various causes of this infective diarrhea, that is very important. Okay. So, let me remove this thing. Okay, leave it. Now, acute diarrhea, I told you it is an infective cause. Now, this infective cause, it may be viral infection, it may be bacterial infection, it may be parasitic infection. Understood? Which is most common if I ask you? Please remember it is viral, which is most common. Viral diarrhea is most common in children. And which virus is important? The most common virus, that was a question, rotavirus. Rotavirus. It is the most common virus implicated in the causation of the acute diarrhea in case of pediatric population. Understood? Now, what is the most common bacteria involved? Please remember, it is E. coli. It is E. coli, enterotoxigenic E. coli. What is the most common parasite which is involved? It is Giardia. Giardial amblyia. Understood? So, I can say that rotavirus is the most common overall. Other viruses can be involved, like, yes, adenovirus, astrovirus, calciviridae group. Also, you have Norwalk virus. These are also involved. The bacteria में you have obviously Salmonella, Shigella, okay, and also you have important is Campylobacter. Obviously in parasite you have Giardia and you have Entomino. Okay, these two are very important. Also If there is a history of HIV positive uh, child, then you should also think of cryptosporidium. Cryptosporidium. Okay, so this is very important. Please remember, this is in HIV positive child. This was a question. Understood? So this is overall thing you have to be remembering here. Please remember that if the child is immunodeficient, then only these parasitic infections are manifested. I don't know. So we are discussing diarrhea. What is the definition of diarrhea per se? In a pediatric population, you may define it as a loose stool that is more than 3 frequency or more than 3 times loose stool passed per day. That is, but a better definition would be that there is any kind of change in the consistency of the stool, or a child who used to pass normal consistency stool now passing a watery stool. That is acute diarrhea. Okay, so this is more of a practical definition, and what I told is the book definition. Next, coming into another thing that is going closely with the diarrhea is the dysentery. Understood? So what is dysentery? Dysentery means, here as we all know, here is diarrhea is there, plus there is blood is coming. So the blood which is mixed with mucus. So mucus stool. It's not like stool actually coming, it is a mucus stool which is coming. Okay, that is, please remember, this diarrhea is invariably due to bacterial. So if I ask you in which case I would prefer giving antibiotics, yes, in dysentery as it is usually bacterial, okay, then I should give antibiotics here. But in case of diarrhea, okay, I am not going to give antibiotic. I am not going to start with antibiotic. Which is the most common bacteria involved here? Yes, Shigella. As we all know that Shigella group, Shigella flexneri basically, this Shigella group is very much notorious to cause dysentery. Okay, so please remember this thing. Now the complication of diarrhea is dehydration. Okay, now this dehydration may be, that is divided into no dehydration, there might be some dehydration, or there may be severe dehydration. Okay, please remember this thing, that no dehydration, here the child will be active, the child will be alert. Okay, he can drink water, so active, alert, and can drink water. Okay, here the child is irritable, and child feels thirsty. Okay, child is thirsty and irritable, and here if you see, the child is very much lethargic, and even the child might be unconscious. Okay, very much lethargic or unconscious. The most important thing is the skin pinch. So if you do a skin pinch test here, you see there is no dehydration. That means if you do skin pinching, the skin pinch, if you skin pinch, because of the maintenance of the skin turgidity, there is no dehydration, so skin turgidity is well maintained, so skin pinch will return very fast. So there is very fast, that means less than within 1 second the skin pinch test, the pinched area will be normal. Here it will be slow, that means 1 to 2 seconds. Here it will be very slow. These terms are very important, more than 2 seconds. Please remember this value because they will give this value, na? Very important. These are very much specific values. Okay. Now, this is the main thing over which we will be discussing, because if there is no dehydration, we have to manage it with plan A regime, basically based on the ORS. If it is some dehydration, we have to manage it with plan B regime, which is basically again ORS and fluid. And if it is a very severe thing, you have to manage it with plan C, where basically you have to manage it with IV fluid. In all the cases, you are going to give zinc. In all the cases, you are going to give zinc. The dose of zinc is very important. If less than 6 months, you are going to give 10 milligram per day, and if it is more than 6 months, you are going to give 20 milligram per day. And zinc is usually given for 14 days, 10 to 14 days. Best answer is 14 days. Why zinc is given? Please remember, because zinc improves, it increases the epithelialization. Okay, so as the epithelialization increased, okay, so what happens? It decreases the frequency of loose stool. And thus it decreases the recurrence, and thus it decreases the hospital admission rate. Okay, this is important. Now, coming into plan A management, that is very important. Plan A management, here we are much more concerned with the replacement of the loss. Because I told you plan A management is done in case of no dehydration. If there is no dehydration, then why I am giving this thing? Because of the continuous loss. As and when the baby is passing loose stool, there is some amount of fluid loss. Okay, and I have to replace that amount which is lost in the stool. That is I am doing in plan A management. So only just by giving ORS, that is very important and sufficient to manage this no dehydration. Okay, so you just have to remember less than 6 months. Remember 6 months to 2 years, and remember more than 2 years. Okay, that's the value you have to remember. So here I am going to give ORS each time the child passes loose stool. Each time the child passes loose stool. So that amount I will be repeating each time the child passes loose stool. Okay, less than 6 months, please remember 50 ml. 6 months to 2 years, it is around 50 to 100 ml. And more than equals to 2, it is around 200 ml. Around 200 ml I am going to give. Okay, this is ORS I am going to give. Sometimes these are asked. Okay, now very important thing, that sometimes they might just give you in glass, like 1/4 of glass, 1/4 to half of glass of ORS, and 1 glass of ORS, just in terms of glass. Okay, this is important. This is plan A management. Plan B management, which is also very important. Let us discuss plan B, where I told you it is the management plan in case of some dehydration. So in some dehydration, there is already a amount that is lost from the body. So that means my body is in deprivation state. So I have to correct that deprivation. So I have to correct that dehydration status of the body. In case of plan A, there is no dehydration, means I just have to give ORS to combat the loss. But in plan B, I have already amount which has been lost from the body, and because of that my body is in a dehydration phase. So I have to correct the dehydration, plus I have to correct the loss. Okay, so sorry, so first is rehydration has to be done. It is to restore the fluid level, and another is replacement of ongoing loss. So if I am saying replacement of ongoing loss, so that does mean invariably that I am going to do plan A management. So simultaneously plan B contains plan A management also. So another thing I have to also consider here is to give a maintenance fluid. So maintenance fluid. So see, there are three things I am giving. My body is in some dehydration. So the baby's body is some dehydration. That means he already had a state of dehydration. For that I have to rehydrate. And this rehydration is done at 75 ml per kg, and this is a loading that is given over 4 hours. And please remember, this is I am giving by ORS. So it is ORS. So ORS is given over 4 hours, 75 ml per kg. So this is to rehydrate and to actually combat with the situation that is dehydration already there. Next, in some dehydration there is already also the child is passing stools again and again. So to stop, to actually combat with that also, each time the child passing stool, again I have to make sure that that loss which is not included in dehydration but going to cause dehydration will be managed by plan A. At the same time, in some dehydration you have to maintain, because if this thing is going on continuously, some dehydration can land up into severe dehydration. So to prevent the progression, I have to actually give maintenance fluid also. Understood? So replacement is accordingly plan A, ORS that is given 75 ml per kg over 4 hours, and maintenance that has to be done, that is very important, by Holiday-Sager's formula. And this maintenance is done for 24 hours. Okay, 24 hours. Holiday-Sager's formula. What is the Holiday-Sager's formula? It is very simple. Okay, they are saying that 10 kg, 20 kg and more than 20 kg. If the child's weight is up to 10 kg, then you add 100 ml to each kg. That means 100 ml per kg fluid have to be given. If the child's weight is more than 10 kg, supposing the child's weight is more than 10 kg, say it is 15 kg, okay, so 15 should be written as 10 plus 5. So 10 kg ke liye I will be giving what amount? Very good. So 1000. So already I have to add 1000 plus extra 5, that will be given as 50 ml per kg. 50 ml per kg. This is important. Okay. And anything more than 20 kg, anything more than 20 kg, so please remember, anything more than 20 kg means you have to add 1500 plus you have to add 20 ml per kg. Okay, I can make you understand this formula also, but no need to that, just you can remember this formula. Okay, if you want to understand, let me explain you also. Supposing less than up to 10 kg, so 100 ml per kg. Up to 20 kg, that means anything extra more than 10, I have to calculate it as 50 ml per kg. So as I said, the example I have given 15 kg, so 15 kg means 10 kg plus 5 kg. So anything up to 10 is 10 ml per kg. So 10 kg के लिए you will be always having 1 liter. Okay, so 1 liter के ऊपर कौन है 5 kg. So you just add 5 and 50 ml per kg. So each kg के लिए 50 ml. So 5 kg के लिए 5 into 50 ml. That will come around 250 ml. Understood? So it will come around 1250 ml. So if it is a 20 kg, then again for 10 plus 10, now this is up to 10, so for that I will be having 1000. This is the next 10, means 10 के बाद you will be having 11, 12, 13, 14, then you will be having 20. So this is the next 10, and in the next 10 I have to give it 10 into 50, that means it will come around 500. So for 20 kg, if I say for 20 kg it will be having 1500. So that is I am taking here also 1500 I have taken. And then anything extra, like if I say 24, so it will be like 20 plus 4. 20 के लिए तो I have 1500, 4 के लिए I will be having extra 20 ml per kg. Okay, that is around 80 ml. So 2800. Understood? That is the thing, and I have given the example also how you have to calculate it also. This is the Holiday Sager formula. Okay, understood. Very good. Now coming into Plan C management. Now Plan C, I told you it's a severe dehydration that needs IV fluid. The IV fluid of choice, please remember, it is Ringer's lactate more than normal saline. Okay. Now there is a rule here. You have to maintain that. You have to actually maintain that fluid rate. Here, whatever you are using, use it 100 ml per kg. Okay. And this 100 ml per kg ka first 30 ml per kg has to be transfused within 1 hour. So in case of child who is less than 1 year of age, okay, having Plan C dehydration, the first 30 ml per kg of the Ringer's lactate will have to be transfused within 1 hour, and the rest of the 70 ml per kg, that has to be transfused over next 5 hours. So if I ask you total within 6 hours, I have to transfuse that 100 ml per kg saline, that is either Ringer's lactate or NS. Okay, but if it is more than 1 year, please remember, then this time will get half. So 30 ml first, initial 30 ml per kg you have to transfuse over 30 minutes, and the rest of the fluid has to be transfused over 2.5 hours. Okay, so here total 3 hours mein you have to transfuse that, total 3 hours. Understood? And in Plan C also there is a chance, so you have to replace the ongoing loss. In spite of giving IV fluid, you have to replace the ongoing loss as like Plan B. ongoing loss. Okay, as you also doing for plan B, that is plan A management, you have to be doing that. Okay, and also daily fluid maintenance, also you have to do maintenance, that is very important. Okay, as I told you, I have to give zinc, and zinc actually helps in epithelialization, decreases the severity and decreases the thing also, decreases the hospital admission rate and recurrence also. Okay, so in this case, please remember, whenever we are using this thing, I told you already, no use of antibiotic, so don't give any antibiotic, no use of antibiotic. Another thing, do you give any anti-motility drug? No anti-peristaltic drug, no anti-motility drugs, like you want to give loperamide, so that is not indicated. Okay, do you give any kind of anti-secretory drug? Anti-secretory drug, like anti-secretory drugs, do you want to give any anti-secretory drugs like resicadotril? No, you don't want. They are all, actually no guidelines are suggesting to give those things. Okay, so no recommendations on anti-secretory, anti-motility, or even you should not give any antibiotic also, unless and until it is associated with some bacterial infection. Please keep in mind. So as we have discussed ORS, let us discuss some facts regarding ORS, then only will be going forward. Okay, so now if it is a dysentery case, you have to use antibiotic, I told you already. If it is dysentery, you have to use antibiotic, and the choice we give is third generation antibiotic, cephalosporin we used to give. We can use cefixime, okay, or even we can use ciprofloxacin, we can use azithromycin also. Okay, if there is severe malnutrition associated, then also we can give, we have to treat it with antibiotic. Okay, if there is cholera, we used to give doxycycline. Okay, and if there is giardia or entamoeba, then we have to give metronidazole. Okay, so metronidazole can be given. Okay, in case of ORS, now please remember, the ORS is oral rehydration salt. ORS is oral rehydration salt. Now ORS, oral rehydration salt, according to WHO, this rehydration salt osmolarity is reduced. So currently we are using reduced osmolar ORS. Reduced osmolar ORS, it is 245 milliosmol per liter. They will ask you what are the individual components actually giving rise to this 245. Okay, please remember, sodium, potassium, glucose, chloride and citrate, these are the things which are there. Okay, sodium and glucose, you all know, they are in equivalent osmolarity. Potassium is 20, chloride is 65 and citrate is 10. Okay, so please remember this sodium and glucose I want to mention, because there is SGLT1, this is a secondary active transporter which is present in our intestine. How to remember? Because we have SGLT2 also in our kidney. So SGLT1 1 can be written as intestine. Okay, so just remember, okay, it is present in intestine. So through that SGLT1 receptor, what is going to happen? Supposing this is SGLT1 receptor, and this is the intestinal, this is luminal side, this is enterocyte. Here what happens, from lumen, sodium and also the glucose is going to enter into the cell in equimolar concentration. That's why we are using both as 75 and 75. Okay, this 1:1 ratio is maintained in the WHO composition. That is very, very important. Now this is for today. Thank you.